Well, we can go ahead and get started, and I will keep letting people in as we go. But I wanted to introduce myself. My name is Shayna Daubert. I'm the director of Kenyon's 50th Reunion Program. And I would like to welcome you to this evening's presentation, Marijuana as Medicine, by Dr. Ted Perrin from the class of 1978. Thank you to the 1972 50th Reunion Committee for hosting this event, to Bill Wallace for coordinating the evening, and to Dr. Perrin for sharing his expertise. Before we get started, I have a few housekeeping items. We will be recording this event to share it with anyone who is unable to join, so everyone will be muted to maintain the quality of the sound. If you have a question, please feel free to submit it in the chat, and time permitting, Dr. Perrin will answer your questions at the end of the presentation. Dr. Perrin also graciously offered to share his PowerPoint with anyone who would like a copy. You can send me an email with your request and I will send you the presentation. My email will be in the chat box. Now I will turn it over to Bill Wallace so he can get us started.
Okay, I'm Bill Wallace, class of 72, and I would like to introduce tonight's speaker, Dr. Ted Perrin, who's class of 78. After graduating with honors in history from Kenyon, Dr. Perrin went to CWRU Medical School and on to an internal medicine residency at Johns Hopkins Baltimore City Hospital. He is currently professor of medical education at CWRU and actively practices addiction medicine and teaches addiction psychiatry at Cleveland's University Hospital and at St. Vincent Charity Medical Center. Ted and I grew up on the same street in Cleveland Heights in the 60s. So in the spirit of reunion, I'm gonna say, this is Billy Wallace saying, Teddy Perrin, let's go.
That's just great. Thank you so much, Bill. And again, thanks to the class of 72 for the invitation for a youngster from the class of 78 to join you all here this evening. It's absolutely my pleasure. And this is one of those topics where there's some medicine, there's some science, and there's a lot of politics, and there's a lot of strong feelings, just like seemingly everything in America these days. So this shouldn't be different than anything else. I'm gonna try to share my screen here. Maybe this will work, we'll see. Okay, so let me move along. The brain doesn't really have marijuana receptors. The brain has receptors for endocannabinoids. The brain makes its own cannabinoid-like chemical or THC-like chemical. This is one of them, but the brain makes a lot of different cannabinoids, and they have substantial effects in the brain. And just by dumb luck, THC is a cannabinoid that comes from a plant that tends to can cross-react with the endocannabinoid receptors in the human brain. Much like opium or heroin or morphine, the opiates that we know of, just by dumb luck tend to cross-react with the endorphin receptors in the brain. So the brain has these endocannabinoid receptors. They're scattered throughout the brain in many areas, as you can see, pretty much all over the brain. But they have substantial concentrations in the area of coordination, which is in the back part of the brain, the cerebellum. In parts of the brain where memory, reward, and judgment live, that's where the euphoria takes place. But from a medicinal standpoint, if there are medicinal effects of cannabinoids, many of the medicinal effects are thought to take place up in here. And they involve areas of the brain that are involved in development, memory and cognition, motivation, appetite, major effects in the appetite area of the brain. I mean, the old joke that when people smoke pot, they get the munchies and eat everything that isn't nailed down in their own dorm room and in everyone else's dorm room was absolutely true. A lot of pizzas got eaten in Gambier, Ohio as a consequence. Some areas of immunologic function, reproduction, movement and coordination, that's that cerebellum effect down here, And then areas of pain regulation and analgesia. There are 60 or so cannabinoids in the plant that we call marijuana. 60 or so of them. The primary one is delta-9 THC, or just plain old THC. It's the most psychoactive and it's the least therapeutic. So the most euphoric cannabinoid that is in the marijuana plant is probably the one that has the least therapeutic value, other than stimulating appetite and maybe decreasing nausea. CBD, cannabidiol, is in the cannabis plant or the plant that we call marijuana, and it may have more of the medicinal effects, if there are medicinal effects in marijuana. But then there's a bunch of others. There's CBN, THCV, CBC, CBL. Starts sounding like a bunch of Canadian broadcasting stations, and about 60 others. So cannabis is a complicated plant. Now, THC itself has its primary effects in this area of the brain. This is where THC has its primary effects, and also back in the cerebellum. The joke in high school is if you have a high school student who's a promising potential Division I athlete, and they begin to regularly smoke pot, they'll become a middle-of-the-road Division III athlete. Because THC does have substantial effects on coordination, and especially twitch reflex coordination. Now, the exception that proves the rule is the NBA. It's sort of the NBA is sort of THC incorporated, and a lot of people, playing some pretty high-level sports. But what can you say? In general, THC has some substantial effects on coordination and twitch reflexes. But this is the area of the brain. The blue circle, the red dot, and then the blue projection to the front is where the euphoria takes place. And these other areas of the brain is where some of the impaired memory and some of the learning and some of the adolescent issues that are so problematic with THC come into play. Just a very quick side note for any of you who are parents or grandparents or pediatricians or psychiatrists. The nexus between marijuana and ADD and ADHD. Moderate to heavy marijuana use absolutely mimics the signs and symptoms of ADD and ADHD. And smoking marijuana or using marijuana, using THC, can negate the therapeutic effect of the psychostimulants that are used to treat ADD and ADHD. So Adderall, Ritalin, Vyvanse, Cylert, and all of their kissing cousins. The therapeutic effect of these psychostimulants can be negated by the use of THC, but THC boosts the euphoria from those psychostimulants. And it may well not be possible to accurately diagnose ADD or ADHD in a person who regularly uses marijuana. Yet, 80% of pediatricians have never checked a tox screen in their entire professional life on a patient. But they diagnose ADD and ADHD not uncommonly. And if you think about people who work, with high school students, later adolescents, and college students around ADD and ADHD, it's really hard to treat the true disease of ADD and ADHD if a person is smoking the antidote to the therapeutic drug. This is where, if you look at this green crescent, this is where the therapeutic effect of the psychostimulants take place. Things like Ritalin, Adderall, Vyvanse, Cylert. Now, if we look at the THC effect, the THC has an effect in exactly the same spot, but it's the opposite. THC is sort of the eraser of Adderall in the brain, except they both boost euphoria. And so the combination of psychostimulants to treat ADD or ADHD, along with the self-administration of THC, negates the therapeutic effect and multiplies the euphoric effect, which is really clearly not any legitimate medical purpose. It might be it might be a legitimate social or recreational purpose, but not a legitimate medical purpose. The marijuana of today is not your grandparents' marijuana. And as a grandparent at this point, I'm allowed to say this. The University of Mississippi has been receiving marijuana bought by the DEA across the US monthly since the early 1970s. And they've been analyzing it for its average THC content as well as CBD content. And as you can see, a joint in 1976, which is sort of right between your all's graduation year and my graduation year, was about 2.2% THC. A joint in 2015 to 2020 is anywhere from 12 to 20%. And so with the marijuana that's out there today, probably a little dab will do you. This is a graph of the increasing THC content in marijuana since 1960, and this is the CBD content in marijuana. So CBD has stayed flat, THC has gone up. People breed marijuana in order to sell it. And people who want to buy marijuana want THC. And so marijuana has been bred pretty carefully over the last 40 to 50 years in order to maximize what people who buy it want. And people who buy it don't want CBD. They want THC. So cannabis is a plant. And it honestly really isn't a medicine, even though it may have some medicinal effects. There's 484 known biological compounds in marijuana, in cannabis, in the flowers, in the seeds, the leaves, the stems. There's at least 84 brain active cannabinoids in cannabis. THC is the primary euphoriant, as I said before. CBD has little euphoria effect and much less of an effect on learning and memory than THC has. CBN, and these are the big three cannabinoids that most of the research is being done on right now is THC, CBD, and CBN. CBN sort of has intermediate euphoria and may produce some analgesia or some pain relief. Marijuana has clearly been used as a medicine throughout history. And, you know, Dr. Baker and Dr. Rutkoff, my favorite history professors back when I was a history major at Kenyon, thinking maybe I would try to go to med school, taught me a ton about looking at history. And so I'm really, really interested in the history of medicine and the history of a lot of these sorts of old medications. In Chinese history, Chinese medicine going back as far as 10,000 years, it's reported that cannabis was used. And it's still a basic herbal in some traditional Chinese medicines. Ancient Egypt, 5,000 years ago, marijuana was used for GI type things, hemorrhoids, spastic colon, what we would call irritable bowel syndrome today. In India, it was used for digestive problems, for insomnia, and for pain. In ancient Greece, it was used extensively in veterinary medicine for tapeworms and such, but also in people. And in the Middle East, it was used as an anti-nausea drug. Now, I think it's important to think about those themes. So GI type symptoms, pain, vomiting, those are some of the anti-epilepsy in the Middle East. Those are some of the things that that marijuana is being used for now. Even, I mean, in early Western medicine from the 1800s to the 1930s, in Europe, it was used for muscle spasms and stomach cramps. Again, muscle spasms, think about increased muscular spasticity. And it was used widely in America in patent medicines. And today, it's being advocated for many of those same things that it's been thought about over the, oh my gosh, over 10,000 years. insomnia, pain, nausea and vomiting, decreased appetite and weight loss, muscle spasms, epilepsy, glaucoma. Every legitimate ophthalmologist I have ever met says if you have glaucoma and you want to use medical marijuana, God bless you, but stay on your real glaucoma medicine too. Otherwise, you and your medical marijuana will go blind. That's just what they say. So glaucoma is probably a red herring. These are some of the patent medicines that were available in the U.S. And they all kind of bought the farm in 1930. In 1930, Congress passed a law making cannabis in patent medicines illegal, and so these guys sort of went down the drain. Today, when we think about a medicine, we've got some standards that we generally expect medications to live up to. And we have some agencies that we ask to vet those medicines in order to decide whether they're safe or not. One of those primary agencies is the FDA. As we've all seen with this pandemic and waiting for the FDA to okay a vaccine, and then okay another vaccine, and then okay booster shots, and then okay the vaccine for people 12 to 18, and then 5 to 18, and now those of us with small grandchildren are sort of on pins and needles, hoping that the vaccine will be okayed soon at the right dose for toddlers and infants. And it's because of this. What we expect from the medicine these days is, number one, what's in it. And the purity of the various things that are in it. Its indications, and the indications are the diagnoses that that a medicine should be used for. And we identify diagnoses in America based upon prospective randomized controlled trials that are peer-reviewed and that are replicated over time, and then reviewed by the FDA to decide whether it's an appropriate indication. Phase 1 trials are to decide whether things are safe. Phase 2 trials are to figure out the doses and the dose-response relationship and the toxic therapeutic dose. And then phase 3 trials are large trials to try to figure out whether a potential medication is broadly safe over thousands of people. That's what we do. And we expect quality research to determine these things. And that's sort of what's expected today in terms of a medication. And I think Americans are much more aware of this today after the pandemic, or during the pandemic, I guess we're still in it, than perhaps we were before. But physicians and pharmacists and dentists and other healthcare providers were aware of this for a long time. So what's the evidence today for cannabis? And I think it is probably best to call it cannabis, medicinal cannabis, for cannabis or marijuana as a medication. In terms of nausea and vomiting in cancer chemotherapy, so not just general nausea and vomiting, but for people with severe nausea and vomiting in cancer chemotherapy, a really, really large review, both in 2010 and then that was repeated in 2020, said it was probably effective for children with chemotherapy-induced nausea and vomiting, but it had a lot of side effects. And there was inadequate evidence of its effectiveness in adults to come down one way or the other in terms of recommending it. A European large analysis of several small studies indicated that synthetic cannabinoids, and this is not cannabis, this is called Marinol. This is a prescription pill of THC. That synthetic cannabinoids, or Marinol, was better than many of the anti-nausea medicines that were on the market. Glaucoma, probably not effective. HIV wasting syndrome, this is the area where THC first came on the market. THC is a prescription medicine. It's a Schedule III drug. It's been available since 1985. I've written prescriptions for THC since 1985 under the trade name Durabinol or Marinol. And I've mostly written it for HIV wasting syndrome. I take care of a lot of patients with drug and alcohol addiction, and there's a big overlap between people with HIV and drug and alcohol addiction. And so I've taken care of a lot of these people and prescribed a fair amount of this, but it's a pill. And when patients have said, well, I'm so nauseated, I can't take the pill, how about pot? Then I can say, well, no, you don't need pot, you need the suppository. And I've never had a single patient in 35 years go for the suppository of THC. They all kind of want to smoke the joint. What can I say? Muscle spasticity. This is an area of tremendous research right now, and it's actually showing some promise. Some variable results in multiple sclerosis. Some pretty good studies indicating that people subjectively report that they have less spasticity and discomfort from fairly advanced MS from medical marijuana or straight THC. Insomnia, again, a few small studies showing some promising results. Pain, some benefits, but boy, the pain studies are pretty crummy. But there may be some analgesic effects, probably more with CBN and CBD than with the THC. And then finally, chronic GI and GU, so chronic abdominal pain syndromes. Think Crohn's disease, irritable bowel, ulcerative colitis, those sorts of things that we aren't very good at treating as docs anyway. And some of the chronic GU issues with bladder, chronic prostate, and such, perhaps after surgery, etc. There's some small studies indicating some promising results. Again, probably more the CBD than the THC. Couple more of these, and then I'll move on, because this is the sort of stuff that I read all the time, but you guys probably don't want to look at too much of this. It is after dinner for those of us in the East Coast. You'll start falling asleep. Spasticity. Oral cannabis extract, OCE, which is mostly CBD and CBN, probably has some effect in decreasing spasticity, especially in multiple sclerosis. Central pain syndromes are things like fibromyalgia. Fibromyalgia may hurt in your muscles all over your back and in various areas of your body, but it's a central pain syndrome. The hurt is around your body, but the pain is really coming from central areas. Oral cannabis extract, which is mostly CBD, is thought to be to have some effectiveness, and THC may have some effectiveness. And then finally, that same sort of theme that comes out in terms of urinary and gastrointestinal issues. In tremor, people with familial tremor or primary tremor, probably not effective. It's unknown whether it's useful in Huntington's disease. It's probably ineffective, and actually it may be dangerous in Parkinson's disease because it may speed up some of the dementia symptoms that tend to sometimes come along with Parkinson's disease. All right. So, does medical cannabis meet today's scientific standards? In terms of its contents or purity, if you wanted something for a cold, and you could take some Sudafed, or you could take something that had 486 biologic compounds in it, and maybe 80 different cannabinoids in it. It doesn't pass the sniff test for contents and purity. Medical cannabis doesn't. Its indications, well-established indications based on reproducible, randomized, prospective controlled trials, almost none. almost none. The vast majority of the research published about medical marijuana is either very small studies without any control groups, or case series. Not even just and anybody who sort of studies medical research knows that a case series is the weakest of standards for medical research. So we don't really have good indications that are well established. The dosage, again, don't know. A person writes a recommendation for medical marijuana, and then you go to a dispensary, not to a pharmacy, but a dispensary, and an advisor at the dispensary gives you advice on which medical marijuana product is the best based upon the recommendation from your doctor. And any one of you can come to the Cleveland College of Cannabis and do a 12-hour online course and become certified as an advisor in a dispensary. So again, the dosage, there may well be things to this, but the dosage, at least as of today, is unclear. The dose-response relationship, how much THC, how much CBD, et cetera, tends to seem sort of like smoke and mirrors or Reaganomics. The toxic therapeutic ratio hasn't been established very well with medical cannabis. And the quality research to determine the efficacy, the safety, the adverse effects, and especially quality research in special populations like kids, adolescents, pregnant women, and the elderly are absent. There just isn't any. Very few prospective randomized controlled trials. The good news about medical cannabis is that the risks are pretty low. So we might not have very much evidence for it to be effective, but we also don't have a lot of evidence that it's very risky, except for the groups that are in red on this slide. Anybody with a history of a substance use disorder, addiction, medical marijuana is a disaster if it has any THC in it whatsoever. It's unclear whether CBD can precipitate relapses to addiction in a person in recovery from alcoholism or other drug addiction, but it's very clear that THC can precipitate relapses. So anybody with a history of a substance use disorder should avoid cannabis or medical cannabis like the plague. And adolescents, cannabis can be very difficult in terms of brain development, increased risk of psychotic syndromes, etc. And finally, there are FDA approved cannabinoids in America. I already sort of spilled the beans on the first one, Durabinol, since 1985. I had no gray hair when I wrote my first prescription for THC, for Durabinol. And it's been available for a long time. Sesamet just got approved. Sativex has been approved throughout Europe and is in phase 3 trials in the US for cancer pain. And just recently, CBD under the trade name Apoladex, which is purified CBD, has been approved by the FDA for use in that very rare childhood seizure syndrome called Dravet syndrome. All of these, at least according to the FDA and DEA, are controlled drugs. Schedule 3, Schedule 4, or maybe one of them may become Schedule 5, but they're all controlled drugs. One last thing about the delivery system or the route of delivery. The speed of onset, if you eat something, it has a gradual onset. The intensity of the effect has to do with how rapidly it gets into your bloodstream, and the duration of effect to some extent has to do with how rapidly it gets in your bloodstream. And some routes of administration are more medical and some are not. So what are the routes of administration of most medicines that we're used to? Pill, taking it by mouth. Swallow a pill, eat or whatever. Mucosal, absorbed across the mucosal membrane, either as a nasal spray or under the tongue. Topical or transdermal. PR by suppository. Inhaler. But smoked is not a typical thing that people do medically. It's just, if you smoke a euphoria producing drug like THC or opium, you get a higher concentration faster into your brain than if you shoot it IV. Smoking a euphoria producing drug is the optimal delivery system to get the highest concentration the fastest possible into the brain. As I said, it's even faster than using an IV. So medical cannabis may be actually pretty goofy from a medical standpoint, but it's widely legal. I mean, it may not make a lot of sense to most clinicians, but it's here. 36 states have medical cannabis laws for either physicians or physicians, NPAs and NPs to be able to recommend it. Generally, medical marijuana is available in the following way. Usually the pharmacy board registers the patients and the dispensaries. Usually the medical board certifies the physicians and or the PAs and nurse practitioners and the appropriate diagnoses. And then other agencies like the agriculture department or whatever looks at the cultivation, the processing, and the testing. That's generally how it rolls. And the basic rules, and all of these are different between different states, but the basic rules are that patients with certain medical conditions, if they get a recommendation from a licensed physician, again, it's not a prescription, it's a recommendation, can take that recommendation and purchase and use the medical marijuana or the medical cannabis. And they receive a so-called medical cannabis or medical marijuana card, or in Ohio, an affirmative defense card. And an affirmative defense card is your card from the pharmacy board, which defends you if you get picked up in possession of medical cannabis, so that you won't be, charged for, having marijuana. It's a weird thing. The pharmacy board is an investigational branch of state government that investigates most drug crimes in Ohio. And it also is the same agency that gives these people their affirmative defense cards in terms of medical marijuana. If I'm not a medical marijuana user, I don't have an affirmative defense card, but if I was a medical marijuana user, I'd be a little nervous about the State Pharmacy Board of Ohio being the one that was giving me my quote unquote license to use. Physicians recommend medical marijuana, they don't prescribe it, and this is why. Under federal law, still so far, medical marijuana, cannabis is Schedule 1. And any Schedule 1 drug is illegal to write a prescription for. And it's illegal for a pharmacy to stock a Schedule 1 drug. And so that's why physicians recommend medical marijuana, they don't prescribe it. And that's why people go to dispensaries, not pharmacies, in order to get it. And the qualifying conditions, these are the qualifying conditions in Ohio right now. And the ones that are in green, I think are, have some validity, or at least may have some validity once we've got better research. And the ones in red are just plain crazy. You don't get hepatitis C unless you've done IV drugs. I mean, what is the estimate? The estimate is that 97% of Americans who are Hep C positive got it from doing IV drugs. And hepatitis C is a reason to get marijuana? That's just plain goofy. Alzheimer's disease, medical marijuana, cannabis that has THC in it impairs memory and learning. And Alzheimer's disease tends to involve a fair number of problems with memory and learning. That's like, oh my gosh. Glaucoma, again, a bad idea take your real glaucoma medicines, and then just use marijuana if you want it, but don't pretend you're using it for glaucoma. And then PTSD. PTSD and anxiety disorders tend to do badly when they're mixed with euphoria-producing drugs, whether it's opioids, benzodiazepines, alcohol, psychostimulants, or cannabinoids. So, so the anxiety disorders in general are not good things to use controlled drugs for. And finally, you purchase the medical marijuana in a dispensary. This doesn't look like CVS. This is a dispensary from Boulder, Colorado. And this is outside, and then looking through the window, and then this is inside. These are some of the delivery systems for medical marijuana. And these are some of the edibles. So there's, Hempopolis, Hempopolis, hemp lollipops is what it really is. Cannabis pops, cannabis spiked vodka, cannabis spiked Budweiser, etc. This is not a Buckeye leaf, but these are some of the cookies that were there. So for clinicians to recommend or not recommend, and I'm going to go through this very quickly because I know most of you all aren't medical clinicians. But for clinicians, if they're trying to decide whether or not to recommend medical marijuana, first, it's important for all physicians, PAs, and nurse practitioners to realize that almost all malpractice coverage does not cover any recommendations for or against medical marijuana. So if physicians, PAs, or nurse practitioners are in the business of recommending or suggesting medical marijuana for various things, remember, when you're talking about medical marijuana, you may be sort of flying uncovered, so to speak, in terms of your malpractice insurance. That's something that I just saw from the State Medical Board of Ohio in the last month. There was a really tragic case from a malpractice standpoint. So first, is it in your area of expertise? And that's a yes or a no. Are you certified by your medical board in order to do it? That's a yes or a no. If it is in your area of expertise, which medical marijuana substance do you recommend? The THC, CBD, CBN, 1/3 THC, 2/3 CBD, 1/3 of each. And if you don't know the answer to that, then it's not in your area of expertise. Know which indications honestly might seem to make sense and which ones don't, and definitely know the contraindications. And any patient who's seeing you with a history of or a current addictive disease should not be considered appropriate to be recommended for medical marijuana. And finally, please accept insurance. Very briefly, since I was a history major, I can't help myself. A brief run through the sordid history of the practice of medicine and cash payments from patients. So the first place that we saw cash payment by patients to people, to physicians, was in the late 70s and early 80s in obesity clinics where patients paid cash to the doctors and were given amphetamines to lose weight. Even though insurance paid for the visits, the doctors asked for like $200 in cash rather than the $50 insurance payment. Then in the early 1990s to early 2010s, cash pain management clinics where physicians prescribed large amounts of opioids. And then in 2010 or so, cash buprenorphine clinics where physicians charged large amounts of cash and prescribed the controlled drug buprenorphine for opiate addiction. And now cash medical marijuana clinics. And there's two common denominators between all of those examples. One is cash and the other is controlled drugs. So it really, really bothers me when I talk to my patients who do medical marijuana, the ones that don't have addiction, and they complain to me and they ask me, why won't I be a recommender? Because all the recommenders they can find charge $200 to $300 per office visit, even though insurance pays for the office visits. It just pays $50, not $200 or $300. Ugh. Anyway, aren't those contraindications kind of harsh? This is where my colleagues who very genuinely urge and are advocates for medical marijuana, and they truly believe it's a good idea, this is where they really just rant and rave against me. They say, well, come on, why? What do you mean anybody with a history of a substance use disorder? Well, the bottom line is that all constituents of medical marijuana that have been reviewed as medications by the FDA and DEA have been determined to be controlled drugs. So you ought to treat medical marijuana as a controlled drug. And giving controlled drugs to people with a current or past history of a substance use disorder endangers the patient's health, safety, and potentially life or liberty, which breaks the basic ethical principle of the practice of medicine, which is above all, first do no harm. Sorry. As I said, the primary ethical principle, first do no harm, and a very important secondary ethical principle in the practice of medicine is comfort always. But there isn't an ethical principle in the practice of medicine that says comfort at all costs, even if you damage the patient in the process. So since THC is an addictive drug, it probably shouldn't be given to people with addictive brains. It's just kind of like, duh. All right. Blah, 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 blah. There's probably substantially less risk with the CBD agents than the THC agents. If one does recommend medical marijuana to people, you should monitor them just as if you were giving them a controlled drug with tox screens, so-called PMP or ORS reports, a full treatment plan, corroboration of their symptom relief, and monitoring for aberrant behaviors. And one should accept insurance. So the future of medical marijuana, honestly, is pretty bleak. If any of you are heavily invested in medical marijuana, you're probably doing pretty good right now. And you'll probably do pretty good for a little while. But unless you're invested in medical marijuana through a venue that can rapidly shift to recreational marijuana, you might want to diversify your investments, because it's highly likely that medical marijuana really honestly is a straw man. In almost every state, 2 to 10 years after the introduction of medical marijuana, the states have just gone ahead and legalized the adult use of marijuana. It takes anywhere from 2 to 10 years. And with legalization, over 80% of the medical marijuana market disappears overnight. Now, that doesn't mean that 80% of people who were taking medical marijuana were just trying to get pot, just for their own use. It means two things, probably. It means several things, but at least two things. One, the decrease in medical marijuana once marijuana is legalized is because the medical marijuana was just used as an intermediary to legalization. That's part of it. But another part of it is when it gets legalized, all of a sudden, people can just go to a head shop and buy it, and they don't need to go to a doctor, and they don't need to get a recommendation, and they don't need to go to the pharmacy board and get a card, and all of the rest of that stuff. So I think both of those are involved. It's almost as if when medical marijuana becomes legalized recreational adult use, it's almost like it goes to over the counter, and people can just go buy it. The constituents that actually have a therapeutic effect will eventually be subjected to scientific standards in terms of indications, dose-response relationships, toxic therapeutic relationship, and there'll be good quality research. And that's kind of the end of the road for medical marijuana. It's kind of dull. It starts with a splash and it kind of ends sort of dull. However, I think the future for marijuana in America is pretty bright. 18 states have already legalized adult use. Another 13 states have decriminalized possession. Eventual legalization at this point, I think, is inevitable. It'll be done state by state, so there'll be tremendous variability, just like alcohol. Some states in the US still have dry counties in terms of beer, wine, and liquor. And other states like Ohio sell beer at 2 in the morning in gas stations, which is bizarre. I mean, who on earth, other than a fraternity member at Kenyon College who used to be a member of Delta Tau Delta like myself, who on earth needs to buy beer at 2 in the morning? I mean, the only people who buy beer at 2 in the morning are people who've already drunk too much, blew through what they had available to them at 10 at night, do a DUI to drive to the gas station to buy the beer, and then do another DUI to drive back home in order to drink the beer. It's bizarre what we've done in legalizing alcohol in America. But eventual legalization is inevitable. It'll be state by state. And let's all hope that the legalization will be guided by public health principles. But it's very unlikely that that will be the case. Why is it unlikely that public health principles will guide legalization of marijuana in the US? Because public health principles typically are contrary to maximizing profit. Public health advocacy groups have little, if any, money. And lobbying in the US tends to be the most effective if it's leveraged with money. And finally, public health advocacy tends to be effective in nations that have national health insurance. And so the US is like 0 for 4 in those criteria, sad to say. But the public health principles that I would hope that you all would try to advocate for in your states as marijuana gets legalized are the following. And these also ought to be done regarding alcohol, even though, you know, the horse is sort of out of the barn with that. Limiting access. State stores are a great idea, where they do strict ID checks, they have reasonable hours, they have reasonable quantities of sale, and they have reasonable delivery systems. Limit the age to 21 and above. Tax it as high as possible, but not so high that you encourage, you know, a large black market. And with the tax income, put 1/3 of it into addiction treatment, 1/3 of it into substance use prevention, and 1/3 of it into the general medical budget. But in state after state, it all just goes into the general fund. So please advocate for these things in every state. So I've talked way too long. Let me stop sharing here and see if there's comments, questions, thoughts.
So there are a few questions. So we'll just start at the top and work down. But Edward Forrest wanted to know, how do you define therapeutic?
So there's a medical definition for therapeutic, and the medical definition for therapeutic is that you identify a symptom complex. It doesn't have to be a disease. It can just be a complex of symptoms that cause dis-ease in people. So a complex of symptoms that produce discomfort in people. So that's what you have to start with first. And then you introduce the substance in a randomized controlled trial. And you see if in the people who are on the real substance who have these symptoms, compared to the people who are on the fake substance, the placebo, who have these symptoms, to see if the people on the real substance have a decrease in the symptoms, and therefore an improvement in either their quality of life, which is subjective but very real and legitimate, or an improvement in their function, in their day in and day out function. But it doesn't have to be function, it can just be quality of life. And that's how you separate out whether there's a therapeutic effect of something compared to a placebo in a large group of people who have the same sort of symptom complex or dis-ease.
Okay, thank you. The next question is, let's see, it's from Jeremy Bromberg, and he wants to know, do you have any idea how we educate people to realize the benefits come more from CBD than the high THC percentage?
Yeah, that is a real challenge. Many of the side effects come from the THC. A person who doesn't want to be high but has some belly pains and takes medical cannabis that has a fair amount of THC in it may get some relief from their spastic colon, but may really not like the euphoria. We see that all the time with opiates. I mean, when I take care of people who've had surgery or whatever, what was common when I was an intern and a resident years and years ago is I'd go see a person who just had their gallbladder out, and they'd be laying in bed sweating with a fast heart rate, clearly uncomfortable, because gallbladder surgery before the robotic approach was major abdominal surgery. And I'd say, oh, you look awful. Have you taken your pain medicine? And they'd say, I'd rather have this pain than to feel how weird that Demerol made me feel. The euphoria is a sort of nasty side effect to many people who are looking for a therapeutic effect of one or another constituent of medical cannabis. Whereas people who are looking for euphoria kind of want that effect. Which is why it's much better for them if they just legalize the stuff and just let them, use it for its euphorogenic purpose. So when I see people who've used medical cannabis and they've complained a lot about side effects, I often say, you ought to go back to your recommender. First of all, I'm not covered by medical malpractice to give advice to people about medical marijuana. So I'm very careful about what I do in my office. But what I do say is you ought to go back to your recommender and talk about the side effects and ask if there are some constituents of medical cannabis like CBD that might be better for your symptom and have fewer side effects. So it's sort of a gentle way to give people the suggestion of what to do. If a person's just sort of buying it over the counter, in terms of CBD, then I just tell them be very, very careful that what you're buying is actually CBD, because we've had a fair number of people in our drug and alcohol treatment programs who are absolutely convinced they bought purified CBD, and now all of a sudden their tox screens are positive for THC, and they're getting in trouble in the methadone programs, et cetera, et cetera.
Okay. Lance Kuhn wanted to know, in addition to its medical uses, is there much information on medical effects over time of recreational use, especially among seniors, like Willie-Nelson syndrome?
Yeah. So remember, THC, so people who use so-called recreational or adult use of marijuana, THC has very real effects on the cerebellum, which involves balance and coordination. And falls in the elderly are a huge concern. I guess I'm allowed to say that now that I'm over 65. Falls in us elderly are a huge concern. And so I recommend to people to be very, very careful, number one. Number two, memory. Memory gets weaker as we get older. I'm sorry, it just does. I hate to see it in myself, but it happens. And THC can have some adverse effects on memory. Marijuana today is much more potent than the marijuana in 1972, or the high point of drug and alcohol use in the US was my senior year at Kenyon, 1978. That was the high water mark for alcohol use in the US. For drug use, not for alcohol use, but for drug use. But the marijuana today is much more potent. And so if people do want to use, and if they're older, I tell them be very, very careful in terms of the amount that you use. The half-life of THC is very long. It dissolves into your fat tissues and continues to come out of your fat tissues. We had an intern when I was the medical chief resident at Baltimore City and Johns Hopkins Hospital, as one of the 3 chief residents. One of our interns just couldn't remember anything. And we were getting ready to let him go from the internship. And he came into my office and said, "Ted, I have a problem." And I said, that's okay. We'll get it taken care of. And then he started to cry. And he said, "No, Ted, you don't understand. I have been smoking marijuana every night since I was 14 years old. I can't sleep without it. And I can't remember whether I wrote for antibiotics for Mrs. Smith when she was admitted last night." And so we sent him to addiction treatment for marijuana addiction, of course. He had a positive tox screen for THC for 8 weeks. I mean, his middle name had to have been Cheech or Chong. He was basically a THC, I don't know, storage unit. But when he came back after 12 weeks to the residency, he was a very good resident. He repeated his internship. He finished his residency. He did a pulmonary fellowship, and now he's an attending doctor in the ICU in an academic medical center in California. But he couldn't remember anything. And that was relatively weak marijuana back then compared to now. So one should be very careful, and it stays in the system for a long time. So one should be pretty careful about dose and frequency. Other questions?
Yeah, so I think we have time for one more question, and then we're kind of at our time mark. Why do you think the FDA approved the medical use of marijuana, given how little research substantiates its efficacy?
So the FDA has, that's a great question. The FDA has identified a legitimate medical indication. That's what the FDA does. They identify a legitimate medical indication for a substance or a drug or a medication. They identified a legitimate medical indication for purified THC in a pill from a pharmaceutical company through a pharmacy. And the indication for it was cancer-induced nausea, cancer chemotherapy-induced nausea and vomiting, and HIV wasting syndrome. And this happened in the mid-1980s when we had 0 treatments for HIV. It was an absolute death sentence. The average life expectancy once a person was known to have HIV was 18 months to 24 months. So this was a 2-year death sentence. And one of the most painful parts of HIV back then is that people had terrible loss of appetite, and they just wasted away in front of us. And it was clear that THC stimulated their appetite. And anything that stimulates the appetite, the FDA decided for something like HIV wasting syndrome, where we had no other treatment, it was just compassionately appropriate to make it available from a pharmaceutical company through a pharmacy by prescription in a known quantity that was known to stimulate appetite. So that's the THC part. The CBD part is there have been some controlled trials of CBD in this rare pediatric neurology seizure syndrome that's very hard to treat. Dravet syndrome is very hard to treat with typical anti-seizure meds. So you've got a disease which is a disaster for kids, very rare, 1 out of 3 million kids. But anyway, those who have it, it's a disaster. Current treatment is lousy, and they did have enough evidence that the CBD treated that seizure disorder in order to give that an indication too. And those are really the 2 major indications for constituents of medical marijuana today. And everything else is on the web. None of it okayed through the FDA. None of it really well vetted. And you can Google almost any symptom in the world and find somebody out there on the web recommending medical cannabis for it.
All right. Well, thank you so much for your time, Dr. Perrin. We really appreciate you joining us this evening and talking on the subject. There were a few more questions, but would it be okay if people submitted them to me and then I passed them on to you, or how would you?
Absolutely, that would be great. And my
Okay.
email is also on the first slide. It's just tvp@case.edu. And
Excellent.
so feel free to send any questions or further comments at all. I'm more than willing to entertain them.
All right. Well, thank you very much. Thank you to everyone who was able to join tonight. We greatly appreciate it.
Thanks a lot.
Good luck with your reunion, class of '72.
Oh, yes.